Hi guys, let us continue with our topic respiratory tract infections. In our previous sessions, we accomplished upper respiratory tract infections, right? Today, I bring to you the lower respiratory tract infections. Generally, lower respiratory tract infections are classified into three: bronchitis, bronchiolitis, and pneumonia. Today, let us begin with bronchitis. So, what is it? Bronchitis refers to an inflammatory condition of the large elements of the tracheobronchial tree that is usually associated with a generalized respiratory infection. So, bronchitis is nothing but the inflammation of the large elements of the tracheobronchial tree, which is followed by a generalized respiratory infection. We can classify bronchitis into two, that is acute bronchitis or chronic bronchitis. Chronic bronchitis. Acute bronchitis occurs in all ages, whereas chronic bronchitis primarily affects the adults. So, this inflammatory process does not extend to alveoli. So, this limits within the bronchial tree. So, let us see in detail regarding acute bronchitis. Coming to the etiology, so when this acute bronchitis is found, acute bronchitis is most commonly occurs during the winter months. So cold, damp climates and or the presence of high concentration of irritating substances such as air pollution or cigarette smoke, this may precipitate the attacks. So the respiratory viruses are by far the most common infective agents associated with acute bronchitis. The common cold viruses including rhinovirus and coronavirus and lower respiratory tract pathogens including influenza virus, adenovirus and respiratory syncytial virus account for the majority of the cases. So the majority of the cases of acute bronchitis is caused by the rhinovirus, coronavirus, influenza virus, respiratory syncytial virus. And bacteria can also lead to acute bronchitis. So, the frequent cause of acute bronchitis is appears by the infection with Mycoplasma pneumoniae. Other bacterial causes can be Chlamydia pneumoniae and Bordetella pertussis. Now, coming to the pathogenesis, as we discussed earlier, acute bronchitis is primarily a self-limiting illness. Hence, there exists only few data to describe pathology. Generally, infection of the trachea and bronchi leads to hyperemic and edematous mucous membranes with an increase in the bronchial secretions. So, this increase in the bronchial secretion can be thick and tenacious in nature. At the same time, as the result of the infection, there is chance of destruction of the respiratory epithelium, and this destruction of the respiratory epithelium can range from mild to extensive, and this may affect the impairment in the bronchociliary function. So this may impair the bronchociliary function, and at the same time, the hyperemic edematous mucous membranes with an increase in the bronchial secretion further impairs the mucociliary function. So these all factors contributes to the development of acute bronchitis. Now coming to the clinical presentation of acute bronchitis, let us see what are the signs and symptoms of the patient that a person come across. So, acute bronchitis usually begins as an upper respiratory infection with non-specific complaints. So, signs and symptoms can be cough, coryza, sore throat, malaise, headache, fever, which rarely exceeds 39 degrees Celsius. So, cough is the hallmark of the acute bronchitis and it occurs early. So, the onset of the cough may be insidious or abrupt, and the symptoms persist despite the resolution of nasal or nasopharyngeal complaints. Frequently, the cough is initially non-productive but progresses, yielding mucopurulent sputum. Fever, when present, rarely exceeds 39 degrees Celsius and it appears most commonly with adenovirus, influenza virus, and mycoplasma pneumoniae infections. So, on physical examination, you can find out rhonchi or coils moist bilateral rails. So, rhonchis are nothing but the low pitched wheezing sounds. So, this indicates that the bronchi are thickening because of the mucus. And rails means small clicking, bubbling, or rattling sounds in the lungs. And while taking the chest radiograph, we can find out the radiograph is normal. So how we can a diagnose an acute bronchitis case? Typically, this is made on the basis of a characteristic history and physical examination, right? So viral antigen detection test. So this helps to identify respiratory viral antigens from nasal secretions rapidly. So for the rapid identification, we can use viral antigen detection tests. Then cultures or serological diagnosis of mycoplasma pneumoniae. Then culture or direct fluorescent antibody detection for Bordetella pertussis. So this should be obtained in prolonged or severe cases when epidemiological considerations would suggest their involvement. So uh, for the diagnosis of mycoplasma pneumoniae, we can do cultures or serological tests. And if we are suspecting Bordetella pertussis, we can do culture or direct fluorescent antibody detection. Now moving to the treatment goals of the therapy. So our goal is to provide comfort to the patient, and in case of the unusually severe case, we have to treat dehydration and respiratory compromise. Coming to the pharmacotherapy. So generally we should provide symptomatic and supportive therapy. So for that, reassurance and antibiotics alone are often sufficient. We can also suggest bed rest and mild analgesic and antipyretic therapy to relieve the signs and symptoms such as lethargy, malaise, and fever. And to avoid dehydrations, we should encourage the patients to take a lot of fluid. So this possibly decrease the viscosity of the respiratory secretions. We can manage the patient with aspirin or acetaminophen or ibuprofen. So this should be given in a dose according to the patient's age. So this should be administered every 4 to 6 hours. And we should prefer acetaminophen in case of treating children. Aspirin should be avoided because there is, when we are using aspirin, there is chance of development of Ray's syndrome. So we should avoid aspirin in children. So to thinning and loosening of the respiratory secretions, we can use mist therapy and or the use of vaporizer. And in case of healthy patients, there is no benefit to use the oral or aerosolized beta 2 receptor agonist and or oral or aerosolized corticosteroids. And how we can manage cough? So hallmark of the acute bronchitis is the cough. So we should manage it with appropriate medications. So for persistent mild cough, which may be bothersome, can be managed with the help of dextromethorphan. And in case of more severe coughs, we can treat with intermittent codeine or other similar agents. So generally, the use of antibiotics are not recommended. But in case of the patients who persist the signs and symptoms for more than 4 to 6 days, we should suspect there is chance of concurrent bacterial infection. Routine use of antibiotics in the treatment of acute bronchitis is discouraged. However, In patients who exhibit persistent fever or respiratory symptomatology for more than 4 to 6 days, the possibility of a concurrent bacterial infection should be suspected. When possible, antibiotic therapy is directed towards anticipated respiratory pathogens that can be Streptococcus pneumoniae. In case of Mycoplasma pneumoniae, if suspected by history or if confirmed by culture, serology, or PCR, may be treated with azithromycin. Also, a fluoroquinolone with activity against these pathogens may be used in adults. So, in case of if we are suspecting Mycoplasma pneumoniae infection, we can treat the patient with azithromycin. And in case of adults, we can also treat with fluoroquinolones such as levofloxacin. Now, coming to chronic bronchitis. So, what is chronic bronchitis? Chronic bronchitis is defined clinically as the presence of a chronic cough productive of sputum lasting more than 3 consecutive months of the year for 2 consecutive years without an underlying etiology of bronchiectasis or tuberculosis. So, when a person comes across a chronic cough with productive sputum which lasts for more than 3 months of the year for 2 consecutive years without there is any cause, that is without an underlying etiology of bronchiectasis or tuberculosis, then we should suspect the patient is having chronic bronchitis. So usually etiologic agents are not mentioned, but uh, when we are performing cultures, we can rule out the bacteria such as Haemophilus influenzae, Moraxella catarrhalis, Streptococcus pneumoniae, E. coli, Enterobacter species, Klebsiella, and Pseudomonas aeruginosa. So Haemophilus influenzae is found in 45% of the total cultures, and Moraxella catarrhalis 30%, Streptococcus pneumoniae 20%, whereas E. coli, Enterobacter species, Klebsiella, and Pseudomonas aeruginosa are found on 5% only. Now, coming to the pathogenesis. So, as a result of the chronic inhalation of irritating noxious substances, this may compromise the normal secretory and mucociliary function of the bronchial cells. So, as a result of the viral infection, there is chance of necrosis of the bronchial epithelium and destruction of the ciliated epithelial cells. So, you can see the bronchial wall is thickened as a response to these infections. You can see there is a number of mucus secreting glands cells, that is the goblet cells in the surface epithelium of both larger and smaller bronchi is increased. In contrast, smaller bronchi is not having goblet cells in an healthy individual. So, in case of infection, we can see goblet cells is increasing in the smaller bronchi. And hypertrophy of the mucus glands and dilation of the mucus gland ducts are also observed. So, this as a result of these changes, mucus is more in their peripheral airways. So, you can see more mucus in the peripheral airways. So, this further impairs our normal lung defenses. And this increased quantity of the tenacious secretions, that is mucus within the bronchial tree, frequently causes mucus plugging of the smaller airways. As a result, you can see squamous cell metaplasia of the surface epithelium, edema, and increased vascularity of the basement membrane of larger airways, and variable chronic inflammatory cell infiltration. So, continuation of this pathological progression leads to residual scarring of the smaller bronchi, and which augments the airway obstruction, and weakening of the bronchial walls leads to development of chronic bronchitis. Now, let us see the clinical presentation and diagnosis of chronic bronchitis. So the signs and symptoms such as excessive sputum expectoration and cyanosis can be seen, whereas where cyanosis is found in the advanced disease. On physical examination, what all findings are there? So, a chest auscultation usually reveals inspiratory and expiratory rails, rhongae, and mild wheezing with an expiratory phase that is frequently prolonged. So, with the help of the chest auscultation, we can find out that there is inspiratory and expiratory rails, rhongae, and mild wheezing, which is prolonged, can be found on chronic bronchitis. Hyperresonance on percussion with obliteration of the area of cardiac dullness. So, on tapping the area of cardiac dullness, we can find out hyperresonance with obliteration, that is destruction. Normal vesicular breathing sounds are diminished. Clubbing of digits, which also found out on advanced disease, and obesity can also be observed. In case of chest radiograph, we can find out increase in the anterior posterior diameter of the thoracic cage, which is also found, which is observed as barrel chest, depressed diaphragm with limited mobility. And in case while performing the laboratory test, we can find out erythrocytosis, which is also found out on advanced disease. While conducting the pulmonary function test, we can find out the vital capacity of the patient is decreased and expiratory flow is prolonged. So these are the clinical presentation that a patient come across in case of chronic bronchitis. Now coming to the treatment. Goals of the therapy. So our goal is to reduce the severity of the symptoms, to ameliorate acute exacerbations, and to achieve prolonged infection-free intervals. So let us see how we can manage chronic bronchitis with medications. Pharmacotherapy. Oral or aerosolized bronchodilators may be benefit to some patients during acute pulmonary exacerbations. So during acute pulmonary exacerbations, we can a certain patient may have benefit from using oral or aerosolized bronchodilators such as albuterol aerosol. Chronic inhalation of the salmeterol fluticasone combination has been associated with improved pulmonary function and quality of life. So, the combination drugs such as salmeterol and or fluticasone combination inhalation helps to improve the pulmonary function of the patient, and long-term inhalation of the ipratropium or tiotropium decreases the frequency of cough, severity of cough, and volume of expectorated sputum. So with the use of long-term ipratropium or tiotropium, we can manage the frequency and severity of the cough and the volume of expectorated sputum. So generally the antibiotics are not recommended. So nowadays it is becoming more accepted. The Anderson criteria can be used to determine if antibiotic therapy is indicated. The patient will most likely benefit from antibiotic therapy if 2 or 3 of the following are present. So those are increase of shortness of breath, increase in sputum volume, or production of purulent sputum. So if the patient have 2 or 3 of these, then we can suspect the patient have bacterial infection and we can direct the antibiotic therapy. Coming to the algorithm. So this is the clinical algorithm for the diagnosis and the treatment of chronic bronchitis in patients with an acute exacerbation. So, when there is suspicion of an acute exacerbation of chronic bronchitis, we should assess for the cardinal symptoms, that is increase in dyspnea, cough, sputum production or purulence, then changes in patient's normal routine. And if the patient is having any of these cardinal symptoms, we should assess for the risk factors also, such as age, COPD severity, more than 4 exacerbations per year, cardiac disease, home oxygen use, antibiotic use in last 3 months, recent corticosteroid use. So we have to collect all of this previous history of the patient. Then we can classify the patient depending upon the severity of the signs and symptoms and risk factors. In case of the patients with minimal symptoms and no risk factors, we can treat the patient with suggestions such as rest, symptomatic treatment observations. If the patient is showing inadequate response, then we have to re-evaluate the patient and we should perform the sputum culture. In case of the prominent symptoms and no risk factors, we can suspect simple chronic bronchitis, that is acute chronic bronchitis. So for that we can treat with oral antibiotic therapy, drugs such as drugs which are involved in second generation macrolide, second or third generation cephalosporins. Then other antibiotics such as doxycycline, amoxicillin, trimethoprim or sulfamethoxazole can be used. And if the patient is showing inadequate response, we should re-evaluate and should perform sputum culture. Whereas in case of prominent symptoms and risk factors, we should suspect complicated chronic bronchitis. In that cases, if the hospitalization is unlikely with 2 or more than 2 risk factors, then forced expiratory volume 1 is less than 50%, then we should provide an oral antibiotic therapy with drugs such as second generation macrolide, second or third generation cephalosporins, other antibiotics such as doxycycline, amoxicillin, trimethoprim or sulfamethoxazole, as we managed simple chronic bronchitis. And if hospitalization is likely with 2 or more than 2 risk factors, and the patient is having severe symptoms, constant purulent sputum, and the forced expiratory volume at first second of the patient is less than 35%, then we should provide the 3 antibiotic therapy with fluoroquinolone, beta-lactam or beta-lactamase inhibitor. If hospitalized, empiric intravenous antibiotic coverage for Pseudomonas aeruginosa, and we should adjust the antibiotics based on the culture sensitivity tests. So this is the clinical algorithm for the diagnosis and treatment of chronic bronchitis in patients with an acute exacerbation. So here is the list of the antibiotics which are commonly used for the treatment of acute respiratory exacerbations in chronic bronchitis. So these are the oral antibiotics. So the preferred drugs such as ampicillin, amoxicillin clavulanate, ciprofloxacin, levofloxacin, moxifloxacin, doxycycline, minocycline, tetracycline, hydrochloride, trimethoprim, sulfamethoxazole can be provided. Supplemental drugs such as azithromycin, erythromycin, clarithromycin and cephalexin can also be provided to the patient for the management. So this is all about bronchitis. So now you must have understood the chronic bronchitis as well as the acute bronchitis. Thank you.